Hello, this is a video lecture on tissue integrity, focusing on birth, specifically episiotomy, lacerations, hematomas that we had mentioned in the previous video, as well as C-section care. I'm going to start with episiotomy. The number one reason why an episiotomy is done is to enlarge in the vaginal outlet for whatever reason, whether it's a fetal indication, maternal indication. We'll discuss that in a second. Episiotomies up until just very recently were more common here in the United States than overseas. And it was thought that episiotomies heal quicker with less pain than actual lacerations. So in just recent months, it has recently declined. In fact, even in our system, if you do an episiotomy, you have to document the reason why. So it's not like this routine kind of thing anymore. I think the use has declined too because they're finding different methods of supporting the perineum when it's pushing. Because remember, it's not so much just the head and being in control. Sometimes it's the shoulders that kind of do the most damage. So there is different types of episiotomies that I just really don't want to really get into. It's midline, medial, lateral. But just the reason why we would do it would be like in the indication for like a forceps or vaginal delivery, as I had mentioned. A suspected shoulder dystocia. So anytime that you got to get this baby out quick, the baby is in distress. And absolutely, if you need to do it, you're going to do it. They're just trying not for it to be like just this routine reason to cut the perineum. And now the episiotomy, just so even to backtrack, the episiotomy is cut from the perineum, to avoid tearing into the rectum. So when you do cut an episiotomy, it does require suture repair. And the biggest thing that we worry about is infection and pain. It's not very comfortable for our mom. So some things that you can do to prevent an episiotomy would be like a perineal massage. They can do that. Or my story about, the oil, the hot compresses and the oil. All of that are things to avoid it. Position changes in labor. Have that baby come down really, really far during the actual first stage of labor. One of the other things to remember is that, you have to check that afterwards as part of your postpartum assessment. So remember RETA. So we do worry about pain. We do worry about infection. We do worry about bleeding. So you want to make sure that you're taking a look at that incision and keeping it clean, and teaching your patient how to keep it clean is really important for that. Lacerations. So lacerations is like in lieu of an episiotomy. So one of the things to remember too, so if your fundus is firm, and this is going to start making a little bit more sense as we start getting into the postpartum checks, where you want to check afterwards to make sure that the fundus of the uterus is firm, so that it goes back to that process of involution. But if you have a fundus that's firm and you have this bright red trickling, you might suspect that there is something going on with that laceration or episiotomy repair, okay? Because lochia is going to be a darker red. Fresh bleeding from this type of incision or wound is more acute, okay? So again, it could be a slow trickle, it could be an ooze, or it could just be a bleed. Now, one of the things that you have to know for exam purposes is the difference between a first, second, third, and fourth degree laceration. These are more common with operative vaginal deliveries, but sometimes you have patients who come in who are uncontrollable, and they just scream that baby out, and they're kicking their legs and they tear. So you can see on your PowerPoint slide the differences between a first degree, which is almost like a skid mark kind of thing, to a fourth degree, which actually goes through the rectum, and you can see pictures as well. It is very painful. It is very hard to heal, and it takes a lot of time and a lot of education. So one of the big things is the RETA, is that acronym that we talked about. ICE is a woman's best friend for 24 to 48 hours. Making sure you have adequate vital signs, because again, remember, if you're bleeding, you're going to have decreased blood pressure and increased pulse rate. Pain medication. And then also, like, if you don't sit straight up, you might want to get off your bottom, especially because all of those leukocytes are going to go to that area, and there's going to be a lot of pressure with that. Monitor voiding, because it's going to burn. Also, like, high protein helps with healing. and then sitz baths, and that's just using that water bottle might be helpful. Also, Dermaplast spray and witch hazel pads, or Tux pads have been used for hemorrhoids in the past. But what it is, they have a drying agent, so they can be lined along the pad, and they actually help reduce the swelling of an area where there's an episiotomy or laceration repair. Dermaplast spray is just the spray gold. Okay, so you just spray it liberally on your perineum, and that helps numb it up a little bit, and that helps it. Okay. Hematoma is something that's really serious. It is, by definition, it's this localized collection of blood in the loose connective tissue. And basically what happens is, through a laceration or an episiotomy, when they're stitching it up, they missed a layer. So the connective tissue has not been sutured. So basically you're bleeding, pumping into this sutured outer area. And it can build up. It can go retroperitoneal. It is very painful. You're bleeding. Sometimes you have to go to interventional radiology and have it drained. A lot of times, if it's small enough, ice will constrict it. So if one of the things that I want you to think about is that if you ever have a patient who's had a delivery vaginally with either forceps or vacuum and had a repair, and her vitals might be a little off, or she's pale, or she is in the most pain of her life, you need to get her in bed, put her on her side, and look to see if there's a hematoma. That should be a number one risk factor, because after your delivery, yeah, you're going to be uncomfortable, but it shouldn't be the worst pain in your life. Okay, so just keep that in mind. The next thing we're going to talk about is C-sections, and you can see in your PowerPoint the different types of C-section incisions, and the one on the bottom is the low transverse incision, is our most common. That's kind of like the bikini cut. They call it Phanastile transverse incision. You can see the top two are those vertical incisions, the ones that go up and down. Those ones are, if you have those kinds of incisions on the uterus, you're always going to have a C-section. With this one on the bottom, the transverse one, depending on the reason why you had a C-section to begin with, if it was like for a huge baby, chances are you'll have a bigger baby the next time too. So they may just schedule an elective repeat cesarean section, but you can deliver vaginally after this low transverse incision. So there's a lot of complications of C-section birth. So I think about you have this alteration in tissue integrity. Okay, so infection, even UTI, because you're putting a Foley catheter in, or endometritis, depending on the reason why you had a C-section to begin with. That's why sterile technique is so very important. Hemorrhaging is always something that could happen. You tend to have less lochia after a C-section because they go in and they kind of clean it out a little bit, but for whatever reason there might be some more bleeding. UTI, I already talked about. Ileus is common. Anytime your bowels are manipulated during surgery, it kind of stuns them a little bit, but sometimes it takes a little bit for them to get back. So ileus could happen because we're not keeping patients NPO anymore after any type of surgery. They can actually go and have a happy meal, whatever. But the risk for thromboembolism, atelectasis, which is the collapsing of the lung, any type of anesthesia complications, or wound dehiscence are all some of the complications that you might see. One of the things that's not in your PowerPoint that should have been in your PowerPoint is what we do preoperatively. And again, we're verifying the patient data, vital signs, putting them on the monitor, putting in an IV, sending bloods for type and screen or type and cross if necessary, as well as the CBC and diff, making sure consents are signed not only for the surgical case, but also for anesthesia, and also consenting for blood in the rare event that it's needed. Clip and prep the area, so we don't really shave anymore, we clip it, but most people are already shaved down in their peri area. One of the other things that we do is we give this preoperative medications. We call it GERD medication. So it's Bicitra, Pepcid, and Reglan, and that helps neutralize stomach acid, so that when you get you haven't eaten, you're getting the anesthesia, your hormones are all kind of like going crazy, so sometimes you get nauseous and sometimes you vomit. So that helps decrease the chance of aspiration for starters. um, as well as, hopefully you won't vomit, okay? Um, SCDs are placed, to keep those legs pumping, as well as a Foley catheter to eliminate the risk or reduce the risk of us nicking the bladder during surgery. During surgery, our role as nurses is to make sure that the patient is positioned and draped, make sure the grounding pad is on because they use that Bovie catheter, make sure the leg belt is applied, SCDs are secured, prepare the newborn area. So we still have to do everything we can for the baby, obtain instruments and supplies that they need, and then recorder of times when the surgery start, when we entered the room, when we got the fetal heart rate, when the case was started, when the baby was born, when surgery ended, when we left the room, when we got into recovery. So all of that is things that we do that I'm hopefully that you'll have an opportunity to see that this semester. Your immediate post-op care is basically this typical third and fourth stage care. Usually it's with a little bit of extra stuff going on. You have to check the fundus, and even though they've had an incision, you still have to make sure that you're pushing on their fundus just to dispel any clots or any type of bleeding. Promoting bonding and infant feeding, I's and O's, EKG, vital signs, pain control, looking at the dressing, and also the resolution of anesthesia, just to make sure that, anesthesia is, starting to, the return of sensation, I guess I should say, and level of consciousness if they're had general anesthesia. Usually anesthesia is either like a spinal, epidural, or general. General is in the event where they can't get a spinal or epidural in, or it's an emergency and we got to put her to sleep right away. Spinal is usually given on a patient who has a surgical date, so a day of surgery admission. And the epidural is usually somebody who's in labor, who already has an epidural and they try to dose it up a little bit. I like spinals better than epidurals. And they do this thing called Duramorph in it, and it's like this shot of morphine that's in there that kind of lasts for 24 hours, with the opportunity of having some PRN medications if needed. So continued postpartum care for our patients include the regular vital signs and the bubble heart that you'll be learning here very shortly. We debrief, did everything go as planned? Is there any problems? And then our issue is, making sure the patient is comfortable as can be. Gas relief, sometimes they have a lot of gassy issues, especially when the bowels are manipulated. Advancing the diet as ordered, promoting rest, but getting her walking and then getting her voiding, okay? Because they're going home a lot earlier than they used to. And then just making sure that you take a peek at the incision. Excuse me. So again, Rita for the parent for the incision, looking at the incision, redness, edema, ecchymosis, which is bruising, drainage, suture approximation, looking at vital signs, keeping that area clean and dry, teaching your patient about how to keep her incision clean. Stool softeners often are used. All right, that's it for this one. See you soon.